Hi, I'm Dr. Mike C. Parent from the University of Texas at Austin, Department of Educational Psychology, and licensed and board certified psychologist. Welcome to this information session on trauma-informed care. The learning objectives for today's session are to first, define trauma-informed care. Second, to describe some of the controversies in diagnosis of trauma that are related to PTSD criterion A. Third, to recall some of the principles of conducting trauma-informed care. And fourth, to apply trauma-informed care to working with our own patients. What is trauma-informed care? Trauma-informed care has four major goals. First, we seek to understand the widespread impact of trauma on our patients and understand paths to recovery. Second, we want to be able to recognize the signs and symptoms of trauma in our patients, their families, and staff in our clinics. Third, we want to integrate knowledge about trauma into our policies, procedures, and practices in our clinics. And finally, we want to actively avoid re-traumatization in our practice. That, of course, brings us to the question of what is trauma? Most of us are primarily familiar with trauma in terms of post-traumatic stress disorder, the DSM diagnosis. Diagnosis with PTSD requires criterion A, or exposure to actual or threatened death, serious injury, or sexual violence in one or more of these ways. First, directly experiencing it. Second, witnessing the event as it happens to someone else. Third, learning that the event has happened to a close family member or friend. And fourth, having repeated exposure to the traumatic event, such as in the course of work. There is, however, a long-standing debate about whether the specifics of criterion A, a life-threatening event, are necessary for the diagnosis or for trauma-related symptoms to manifest. Prior editions of the DSM said that the event had to be outside of the range of normal human experience and that they'd have to evoke significant distress in almost everybody. However, that's challenging because many traumatic events are unfortunately not particularly rare, and there's no real data to determine what kind of event is outside the range of normal human experience. And finally, evoking distress in almost everybody suggests applying some unknown norming standard to idiosyncratic responses, which can be challenging. In another previous edition of the DSM, wording was added that specified that the event was usually experienced with intense fear, terror, or helplessness, and indirect exposure was added as it remains in there. The main critique of all these alterations throughout was that the scope of trauma had become too broad, or that it was too narrow. This comes up a lot because PTSD is the only mental health diagnosis that actually requires a qualifying stressor. We can diagnose basically anything else without that kind of stressor. People who have depression don't need to have some kind of depressive event happen. People who have anxiety don't need to have some anxiety-provoking event. And even people who have phobias don't need to have had some traumatic experience with the thing they're phobic of. In fact, many or most of them don't. For example, we diagnose water phobias all the time in people who never nearly drowned, and people can have arachnophobia after having never been attacked by a poisonous or dangerous spider. We also know that experiencing things that may not be life-threatening, but that are stressors, such as chronic harassment or discrimination, may bring about PTSD symptoms even if they don't result in meeting the criteria, because of criterion A, for PTSD. All that is to say that often trauma-informed care as a concept applies to folks who may not have PTSD diagnoses, but may have these experiences of persistent, chronic stressors in their lives. So let's talk a bit more about trauma-informed care. The Substance Abuse and Mental Health Services Administration, or SAMHSA, in 2014 published a list of principles of a trauma-informed approach. These principles were safety, trustworthiness, peer support, collaboration, empowerment, and cultural, historical, and gender responsiveness. Let's talk about each of those one at a time. First comes safety. Safety is defined as organization-wide and means that the staff and the people that they serve, children or adults, feel physically and psychologically safe when they're in care. That is, the physical setting promotes a sense of safety, and the interactions that the patients have make them feel safe. Safety should essentially be defined by those who are served. SAMHSA's second principle of trauma-informed care is trustworthiness and transparency. This means that organizational decisions and operations are conducted with transparency. And the goal here is to build and maintain trust with patients and their family members. And that trust has to be built by staff, providers, and the organization overall. The third principle from SAMHSA was peer support. Peer support and mutual self-help are important avenues to establish safety and hope and to build trust and enhance collaboration. Things like stories of lived experiences can be used to promote recovery and healing, with peers being individuals who have lived experiences of trauma. In the case of children, this might be family members who've experienced traumatic events rather than the children themselves. The fourth SAMHSA principle was collaboration and mutuality. This involves partnering and leveling of power differences between staff and the clients they serve. It also involves collaboration among staff. So, for example, between clerical administrative staff and housekeeping staff and professional staff and administrators. The idea here is that healing happens in relationships and in the meaningful sharing of power and decision-making among the stakeholders in the organization. By doing this, the organization recognizes that everyone has a role to play in enacting a trauma-informed response. A relevant quote here is that one doesn't have to be a therapist in order to be therapeutic. Front desk staff and clerical staff can provide an initial welcoming experience to patients that helps them make them feel like they want to engage in care. The fifth principle was empowerment, voice, and choice. This involves an organization-wide effort to build on individuals' strengths and experiences and recognize those. The organization here would foster a belief in how important it is to work for the people who are being served, foster a sense of resilience, and prioritize the needs of individuals, organizations, and communities to help to promote recovery from trauma. So in enacting this, organizations would work to understand ways in which clients historically have been diminished in terms of their voice and their choice in terms of treatment options. In a trauma-informed approach, clients are supported in shared decision-making, choice, and goal setting to determine a plan of action that can help them to heal and move forward in an engaged way with their treatment. In this aspect of trauma-informed care, staff are also empowered to do their work as well as possible by having adequate institutional support. That is to say that staff, as much as clients, need to feel safe in performing their work and providing services. The sixth principle was cultural, historical, and gender issues. In enacting this, the organization actively moves past cultural stereotypes and biases. The organization can offer things like access to gender-responsive services, it can leverage the value of traditional cultural connections, and it can incorporate policies, procedures, and processes that are responsive to racial, ethnic, and cultural needs of individual clients. In enacting this, too, the organization would recognize and address historical traumas that have occurred within the service setting. Related to those, SAMHSA has 10 implementation domains. The first is in policy. Addressing trauma-informed care policy means asking questions like, how do the agency's written policies and procedures include a focus on trauma and issues of safety and confidentiality? How do the agency's written policies and procedures recognize the pervasiveness of trauma in the lives of patients and commit to reducing re-traumatization of patients? How do staffing policies demonstrate a commitment to diversity, and how do staff trainings support culturally relevant and trauma-informed care as part of the organization's orientation? And what sort of policies and procedures are in place for including trauma survivors or people receiving services in peer support and meaningful and significant roles for them in agency planning activities? SAMHSA's second implementation domain was in governance and leadership. Here the questions are things like, how does the agency leadership communicate support, guidance, and implementation of a trauma-informed care approach? How do things like the mission statement and the vision statement and written policies and procedures include and enact that commitment? so that it's actually incorporated into steps of project management? And how do leadership and governance structures reflect and demonstrate that the administration actually cares about the voices of people who have experienced trauma in care? SAMHSA's third implementation domain was in the physical environment of the organization. This includes questions like, how does the physical environment promote a sense of safety, calming, and de-escalation when needed for clients and staff? And how has the agency developed mechanisms that can address physical and emotional safety concerns that can be related to factors such as gender, race, ethnicity, gender identity, or sexual orientation? The fourth implementation domain from SAMHSA was engagement and involvement of people in recovery, trauma survivors, people receiving services, and family members receiving services. Here, the questions are things like, how do people with lived experiences have the opportunity to provide feedback to the organization or the clinic on quality improvement processes for better services? How is trust and transparency among the staff and clients promoted? And what strategies are used to reduce the sense of power differentials among staff and clients? SAMHSA's fifth implementation domain was cross-sector collaboration. Here, the questions are things like, is there a system of communication that exists with other partner agencies to help make trauma-informed care decisions? Do the partners of the organization also endorse and enact trauma-informed care approaches? And how does the organization identify community providers and referral agencies that have experience in dealing with evidence-based trauma services? The sixth SAMHSA implementation domain was screening, assessment, and treatment services. This focuses on issues such as, is an individual's own definition of emotional safety included in treatment plans? Does the organization have the capacity to provide trauma-specific treatment, or do they have a good referral system in place? Are and how are peer supports integrated into the service delivery approach? And how are trauma-specific practices incorporated into the organization's ongoing operations? SAMHSA's seventh implementation domain was training and workforce development. This involves questions like, how does the agency address the emotional stress that can arise for staff when working with individuals who have traumatic experiences? And how does the organization ensure that all staff, from direct care providers through to administrative staff and clerical staff, front desk staff, how do they receive basic training on trauma, its impact, and strategies for a trauma-informed care approach? SAMHSA's eighth implementation domain was progress monitoring and quality assurance. This involves questions like, is there a system that monitors the agency's progress in being trauma-informed, and what are those benchmarks? And does the agency solicit feedback from staff and clients who are receiving services to know if it's on track? SAMHSA's ninth implementation domain is financing. So does the agency's budget include funding for ongoing training and trauma-informed approaches for leadership and staff professional development? And how does the budget reflect prioritization of a physically safe environment? SAMHSA's 10th principle of trauma-informed care is evaluation. This involves questions like, how does the agency conduct a trauma-informed approach organizational assessment, or have measures or indicators that show their level of trauma-informed care approaches? And what processes are in place to solicit feedback from people who use services, while ensuring their anonymity and confidentiality? Let's talk a bit about research on trauma-informed care. We'll start with this study. Adverse childhood experiences, or ACEs, are experiences of trauma during childhood. ACEs are linked to negative health behaviors, including tobacco use. But we also know that resilience can help to buffer against the negative impact of ACEs. And one way that resilience can show up is through the presence of a stable, safe, and nurturing relationship that occurs in childhood. In this study, the authors used data from just over 7,000 people in the 2016 South Carolina Behavior Risk Factor Surveillance System. They looked at smoking and e-cigarette use as dependent variables, and they looked at independent variables of ACEs, which included household mental illness, household substance use, household incarceration, and household violence, parental separation and divorce, and physical, emotional, and sexual abuse experienced during childhood. They also assessed for the presence of safe, stable, and nurturing relationships in childhood. They found that 75% of people with ACEs, so with adverse childhood experiences, were smokers, compared to 25% of people who did not have ACEs. And 85% of people who had experienced ACEs were e-cigarette users, compared to only 15% among people who did not experience ACEs. Smoking and e-cigarette use were higher for people who had a history of ACEs and who also did not have a safe, stable, and nurturing relationship during childhood. The take home here is that many people who smoke and who are trying to quit may have very important trauma histories that can impact how they approach quitting and how successful they might be in their quit attempts. We also know that trauma histories can impact how treatment goes. In this study, the authors looked at just over 1,500 women who were attending maternity clinics, and they assessed tobacco use and trauma histories. People at the clinics who were smokers had higher rates of current and lifetime post-traumatic stress disorder. Smokers were also more likely to experience PTSD hyperarousal symptoms and to classify their trauma experience as extremely troubling. So people with worse trauma experiences tended to be smokers more often. Also, participants who reported that they smoked to cope with emotions and problems were 2 times more likely to smoke while pregnant, after accounting for multiple control variables. So the authors put forward that trauma-informed care can improve prenatal health care and tobacco cessation, and that care has to be adjusted to account for how trauma might be impacting patients, to improve the working alliance and to enhance retention and outcomes for patients. Of course, there's also the provider side of trauma-informed care as well. In this study, the authors interviewed 13 psychiatrists in Australia about trauma-informed care. 4 major themes emerged. The first theme was making sense of trauma. The onset of trauma is complex. There's usually multiple traumas, and traumas often cause multiple symptoms, psychological, behavioral, and physical. And the authors also found that the participants noted a sense of disagreement in the opinions among them and their colleagues of broader definitions of trauma that might include things not included under criterion A of PTSD. The second major theme was seeing trauma and its interaction with mental illness in terms of being a cause, effect, and a comorbidity with regard to mental illness. So it's not as though trauma causes mental illness or mental illness causes trauma, but that they interact in a complex way that can make treatment more complex in many cases. And relatedly, the third theme was trauma makes treatment more complex. So patients may have symptoms such as relational or emotional instability, problematic coping mechanisms such as smoking, or other stressors. And the final theme was that trauma-informed care highlights tensions in care. So most of the providers felt like they already enacted most aspects of trauma-informed care, and often saw efforts to improve trauma-informed care as vacuous or being lip service when they didn't have actual organizational support. In terms of practice considerations, there are 4 suggestions in the literature. The first is validating and normalizing clients' feelings and experiences, that many people have had really terrible experiences in care that have been re-traumatizing. Second, assisting patients in understanding the past and its emotional impact, so helping them to understand that their past can be impacting their current behaviors. Third, empowering patients to better manage their current lives, so providing them with resources and tools to do that. And fourth, helping patients to understand their current challenges in light of past victimization or trauma experiences. These come with some challenges though. So some patients will not report a trauma history, no matter how good your organizations or personal efforts toward trauma-informed care are. The most that can be done sometimes is to provide a supportive context, so that maybe at the second or third or fourth visit, if the patient is retained in care, they will disclose the trauma history and there can be movement forward on that. It's also true that memory of trauma can be limited. So research indicates that recovered memories are not reliable, and efforts to uncover those suppressed memories are more likely to create false memories than uncover supposedly buried ones. But many people have hazy memories. It's not as though memory is a recording of the events that transpired. And so the memory of traumatic events might be very limited. That's particularly true when the trauma occurred at a young age. Mandatory reporting can also create some challenges. Many clinicians don't know the rules about mandatory reporting. They might not have refreshed themselves since training on mandatory reporting and may not report correctly, or they may experience their supervisors as pressuring them to not report incidents that really should be reported. And another danger here is that reporting can increase risk in some ways. So reporting physical abuse in the home might risk an increase in physical violence in the home when the perpetrator reacts to being reported. And finally, for some clinicians, exposure to constant trauma prompts experiencing secondary trauma, or basically being traumatized by this recurrent exposure to traumatic experiences, which actually can meet criterion A of PTSD. There have been some recommendations for applying trauma-informed care to tobacco use in particular. First, the recommendation is to include harm reduction and the importance of other aspects of health, like nutrition and exercise, to avoid a sense of blaming the patient for what the patient sees as their go-to stress relief coping mechanism right now, so smoking. Trying to avoid blaming the patient for smoking and instead supplying them with some resources to potentially find other mechanisms of coping, such as exercise. We'd want to avoid judging, shaming, or punitive approaches that are more likely to result in the patient just disengaging from care. So, for example, if a patient smokes around their children, being judgmental or punitive or shaming of that is more likely to result in the patient just disengaging from care than stopping the behavior. We also want to assess the context of the patient's life and experiences of things like persistent harassment and discrimination. So, for example, if a patient who is LGBTQ+, works in a discriminatory environment where they're constantly hearing slurs or anti-LGBTQ+ jokes or things like that, maybe smoke breaks are a respite from that toxic workplace. And in that case, it's going to be a lot harder to have the person quit because by not going for their smoke break, they're continuing to be exposed to this negative environment for even longer. It's also vital to remember that traumas might not be revealed early in treatment, even when you ask about them directly. Or maybe you do ask about them directly and the patient says something like, I've already dealt with that, I'm over it. And it's not until a couple sessions in that the patient discloses a trauma history or that aspects of that history might still feel with them. The learning objectives for today, again, were to define psychological trauma, to describe some of the controversies in the diagnosis of trauma related to criterion A of PTSD, to recall the principles of trauma-informed care, and to understand how to apply some of trauma-informed care principles to our own interactions with patients. Again, I'm Dr. Mike C. Parent from the University of Texas at Austin, Department of Educational Psychology, and licensed and board-certified psychologist, and I hope that this presentation has been useful to you in your clinical practice.